morning. Hi, everybody. My name is Sam Siddiqui. I am the Director of Female Pelvic Medicine and Reconstructive Surgery. And that's the specialty that you guys know it as urogynecology. Has everybody heard that term, urogynecology? No. So a urogynecologist is a doctor that has training in several areas. My main training is gynecologic and urologic, urogynecology. But I also have some training in rectal surgery, geriatric medicine, a little bit of plastic surgery. So I treat women's problems down there, okay? And basically the main things that I'm going to talk to you about today are urinary incontinence and pelvic organ prolapse. So if that's what you have questions on, this is the right place. If you have questions on breast health, that's this afternoon. Just want to clarify that, okay? Nobody's walking out? Okay, very good. So basically what I'm talking about happens very, very often, okay? 1 in 2 women is going to have some type of prolapse in their lifetime. 1 in 3 women is going to have some type of pelvic floor dysfunction in her lifetime. 1 in 5 community women is going to have urinary incontinence that's going to need to be treated, okay? The problems that we're going to talk about today are not emergencies. They're not life-threatening. They're problems that you can put off, but they affect your quality of life. So I'm just going to start with just reviewing the anatomy. So basically, I'm a specialist in this area of the body, okay, the pelvis. And I don't deal with orthopedic bone issues. I deal with soft tissues. So the 3 areas are the gastrointestinal area, which is the rectum and anus, the gynecological area, the vagina and the uterus, okay, right in the middle, and then the urological, the bladder and the urethra, where the pee comes out. And all together, all of these areas rest on something called the pelvic floor. So the pelvic floor sounds like a construction zone, doesn't it? Have you guys heard the term pelvic floor? Yeah. Well, you're smarter than my last group last year. Because I said that, and nobody's like, no, I've never heard that. Well, you guys are much smarter. I think people are getting smarter. But the pelvic floor is this area that consists of muscles and connective tissue and ligaments that hold the pelvic organs. And they're also the entryway for where you have childbirth, your urine comes out, your feces comes out, okay? So the pelvic floor governs all that. And how does this pelvic floor get damaged? Childbirth. What are other things that can damage the pelvic floor? A little bit. It may affect your bladder a little bit. But what are the real things? Childbirth really damages it. Aging process as we get older, okay? Unless you had a really big fibroid and is weighing down, but not that strong. Age. How about menopause? Okay, how about lifting very heavy things? You work for UPS and you lift heavy boxes. What about constipation? Are there any diseases or any problems or anything that you're doing every day that could affect your pelvic floor? Running's fine. No, running's fine. Sitting's fine. Lack of exercise leads to obesity. And obesity is a risk factor, correct? What else? What if you have like asthma or you're a smoker and you're coughing all the time? Coughing is a big one, okay? So all these things that we just mentioned, mainly childbirth, coughing, heavy lifting, these are all things that affect the pelvic floor. And then there's one that you are born with. Do you guys know any conditions where you're born with something and it's just makes your pelvic floor lax and everything just falling? You probably don't see it that often. I see it more often. But if you have a family member with this, you'll know. Spina bifida, okay? So basically, let me start with talking about urinary incontinence. Urinary incontinence is the involuntary leakage of urine. And when I see patients, they come to me and say, doctor, I'm leaking. I do this, and I leak. I get to the door, and before I'm able to open the door, I'm leaking. When I cough, I leak. When I yell at my friends, I leak. They're telling me all these things. And for me, I try to, I'm a doctor. I'm trying to be scientific and figure out what is the problem. there are different types of urinary incontinence for me. So I try to categorize that. So the main type that people talk to me about is stress incontinence. Stress incontinence is when you have a full bladder, you cough, laugh, sneeze, you leak. It's stress. It's not emotional stress. It's the stress that you're creating by coughing or pushing or straining. Stress incontinence. Do you guys, have you heard the expression, I laughed so hard I peed my pants? Okay, you hear that all the time, right? That's not normal. It's not normal to laugh hard and pee your pants. That's an abnormal thing. Okay, that's stress incontinence. And I've heard that in teenagers who come and say, I laughed so hard I peed my pants. Even a teenager can have stress incontinence. You don't have to get older to have stress incontinence. The other type of incontinence is urge incontinence. And this is very common. This is, I gotta go, I gotta go. This is, doctor, I just can't make it to the bathroom. I suddenly have this urge to go to the bathroom, and when I get there, before I even have a chance to take down my pants, I'm already leaking down my pants, okay? Or doctor, I can't even go anywhere. I have to know every single bathroom from here to the supermarket, because if I have to go, I have to stop somewhere and go to the bathroom. That's called toilet mapping, okay? Toilet mapping. There is an app for that. There's actually an app. It's very interesting you ask. There's actually an app for people who have overactive bladder and urge incontinence for going to the movie. So it tells you when in the movie is the best time to go to the bathroom. When would you, I mean, this is crazy, right? We have to fix this. So it's very common, and it actually gets more prevalent as you become older, unfortunately. Now, all of these things that I'm talking about, they are prevalent as you become older, but they are not normal. Urinary leakage is never a part of normal aging. That's not normal, okay? So don't let any friends say, oh, yeah, I have that. Well, yeah, everybody has that now, but it's not normal. So here's stress incontinence. Here's this is an old image from like an anatomy text, but here's it is pretty funny, isn't it? So this lady has a full bladder, and she's coughing, and the cough pushes on the bladder, and she leaks immediately. It's an instant leakage. It occurs at the same time as the cough, okay? Stress incontinence. This is overactive bladder. Overactive bladder is that you're not really doing anything. It's your bladder that's doing something. It's misbehaving. And your bladder is contracting and squeezing, and she's trying to hold it, but she can't hold it, and then you start leaking. Usually, the volume of leakage with overactive bladder, it's a larger volume. With stress incontinence, it's just spurts when you're coughing. With overactive bladder, it's like you lose control and you're going, okay? That's overactive bladder or urge incontinence. So we'll go into, again, I didn't want to go into too much detail on the pathophysiology and stuff because I want to answer questions. I'll cover the other thing that we should also focus on. The other one is called prolapse, or pelvic organ prolapse. Has everybody heard that term? Yes. So what is prolapse? You've been watching Dr. Oz, and one of the new doctors on Dr. Oz is actually a urogynecologist. She's the first urogynecologist on television. So what is prolapse? Someone who raised their hand. Someone who said, I know what it is. Yes?
My mother, her uterus, her bladder dropped after she had
Right. Right. So prolapse is the dropping or falling of your internal pelvic organs. We're talking about the bladder. We're talking about the uterus. We're talking about the rectum. If you've had a hysterectomy, we're talking about the top of the vagina that can come out like a hernia in the vagina. You don't have to have a hysterectomy to have prolapse. That's a myth. You can have a prolapse with a uterus. Okay? So pelvic organ prolapse, very common. Like I said, 1 in 2 women will develop prolapse in their lifetime. They may not need surgery for it, but 1 in 5 women will need surgery for prolapse in their lifetime. So I was teaching some medical students this morning, and we were talking about life expectancy. What is the current life expectancy for women in the United States? Anybody? Yeah, 80, 81. What was life expectancy in the United States back in the 1900s? Yeah, it was like 40, 45, something like that. So we have almost doubled our life expectancy, right? So what's happening? Over the last century, we're living longer. So when we're living longer, we are our heart is working better so we can keep living. And as we get older, we get all these problems that we never had before. And so there is no medicine for this problem. So as we get older and older, we develop these problems. They're not normal. They're not a normal part of aging, but they do affect our quality of life, okay? So this is a picture of a normal rectum, uterus, bladder. Can you see that? And then over here on the right is a picture of a cystocele. This is where someone's bladder is falling. So here the bladder is in the right place. Here the bladder is falling. And that's called a cystocele. So what symptom would someone with a cystocele have, you think? You could have cramping or pain. Usually pressure, protrusion, discomfort, heaviness in the vagina. Doctor, I can't keep a tampon in. Doctor, I feel like I have to go to the bathroom all the time. Maybe I don't have leakage, but I have to go to the bathroom all the time, and I don't drink that much water. Okay? Or, hey, I'm trying to empty my bladder, but I can't empty my bladder. That's cystocele. Here, this is a patient who has had a hysterectomy, and the top of the vagina is turning inside out like a sock turning inside out. And you don't see it, but if there was, people have intestines, so the intestines would fall into this area and cause a hernia. And that's called an enterocele. Okay? There's another picture of cystocele. Here's an enterocele. You can see the bowel going into the vagina, which is turned inside out. And this is the normal picture. Okay, so why do these things happen? We've already talked about it. We said pregnancy, childbirth. Is it just, what about pregnancy makes you have prolapse? What do you think it is? The heaviness? It's the heavy child? I have a 10. You have a big baby? What about the pushing? Right. So it's the childbirth trauma. Just being pregnant does cause some problems with your pelvic floor. But the most amount of problems occur with childbirth, with the actual process of childbirth. So if you're pushing a really big baby and you tear and all these things happen, you have a rapid childbirth, all of that can cause damage to your pelvic floor. We talked about menopause, aging, obesity, lifestyle. We talked about all these things. Chronic diseases like coughing. If you're coughing a lot, it's pushing down on your pelvic floor muscles. Okay. So what can you do? Is there anything we can do besides having surgery? Yes, there is. So we said lose weight, because obesity is always a problem. It's not just a health problem for your heart and other parts of your body, also for your pelvic floor. Lose weight, easier said than done, because I've tried myself to lose weight all my life. I've gained weight and lost weight, and it's such a difficult thing to do. It's actually not hard to lose it, but it's hard to maintain it, right? But, there is no magic pill out there. There are some new pills, actually, diet pills. But there is no magic pill that makes you lose weight. You have to just have a healthy diet and exercise. Those are the main things. Go to Jenny Craig's or something, but, lose weight. Stop smoking. So we talked about cigarette smoking. Cigarette smoking is, it's irritating to your bladder. It irritates your bladder and makes your bladder want to contract. So if you have urge incontinence and overactive bladder, it gets worse. Smoking makes you cough. So if you're coughing, that affects your pelvic floor. Smoking also makes it difficult to heal if you're going to have surgery. Smokers actually tend to be thinner. Have you realized all their smoking, if you have smoker friends, they're always thin. They are thin, but they're actually sicker inside because they don't heal well. Reduce stress. So stress can affect your bladder. Stress affects your bowel even more than the bladder. Anyone heard of the term irritable bowel syndrome? Irritable bowel syndrome is a condition that we don't really understand that well. And when somebody has constipation, diarrhea, bloating, mucus from their, we do all these tests and all the tests come out normal. They don't have an infection, they don't have lactose intolerance. Well, what is it? It's IBS. It's this wastebasket category. But IBS is very strongly affected by stress. And so is overactive bladder. Overactive bladder and interstitial cystitis. Have you heard of that term? Interstitial cystitis is this condition of the bladder where the bladder doesn't fill very, very well. It's kind of thickened. You feel like you have to go to the bathroom all the time. You go to the bathroom 20, 30 times a day. It hurts to have intercourse. You always feel like you have an infection, but every time you go in, it's negative. That's interstitial cystitis. Those conditions are affected by stress. Drink appropriate amounts of fluid. I can't tell you how many times I see women coming to my office and they have a venti Starbucks cup sitting there and they say, "Doctor, I'm going to the bathroom so many times." And I'm looking at that and say, "How many of those do you drink?" Right? So the amount of fluid and the type of fluid. Obviously, caffeinated beverages, we'll get to caffeine in a second. But if you have overactive bladder or stress incontinence, you want to limit the amount of fluid you drink. All of your lives, you've been told that my doctor wants me to drink more. Right? You should drink, drink, drink. Drinking is healthy. Okay? It is healthy up to a point. You don't want to be dehydrated. So a typical person should only drink, give me a number. How many cups of fluid, total fluid, should a typical person drink? 6 to 8, yes. 6 to 8 cups. Not glasses, cups. 6 to 8 cups. So if you have overactive bladder and you're drinking like, you say, "Yeah, doctor, I drink about 5 bottles of water." That's a lot. What's a bottle? How many cups is that? That's 2, right? That's a lot. So you don't want to overwhelm your system if you've got urge incontinence and overactive bladder. You want to keep it on the 6 side. Now, don't go home and say, Dr. Siddiqui said to dehydrate myself or drink only 6 cups. If you're going out in the sun, if you're a construction worker, you're doing heavy, or you're exercise, you do need more, right? If you exercise, you need more. But if you're just around the house doing work and normal activities and stuff, 6 is fine. Okay, so that'll help. Oh, by the way, you can go the other way too. I have had patients who don't drink at all. And that's not good either. That's not healthy for you. That concentrates your urine and makes the urine irritate your bladder, so then you have more incontinence from irritation. Okay? Yes, and that's my next. I think it's in here. There. So caffeinated beverages. Caffeinated beverages, caffeine makes the bladder kind of contract more. Okay? So we tell people to reduce their caffeine intake. Green tea is a big one. Green tea really makes you want to go to the bathroom. Yeah, that's a big one. That's a big one that people don't realize. Okay, who knows, what do you guys think about cranberry? Because cranberry is so out there. Every time I see a patient, "Yeah, doctor, I'm drinking 5 glasses of cranberry." Is cranberry juice good? Too much sugar, so it's not good for that. Okay, let's say you get unsweetened, really, healthy cranberry extract juice. Is that good? It is acidic, so it's irritating to the bladder. Why were we drinking cranberry all these years? Why were we doing it? Because we didn't want to have a bladder infection. Because some person came up and said, the material, the molecules in cranberry prevent bacteria from binding your bladder, right? So theoretically, it made sense. We have had so many studies now. I just read another study. It was well designed. Cranberry extract juice, cranberry does not prevent urinary tract infection. So all these years we've been taking cranberry, and all it's doing is irritating our bladder. It's because it's acidic. No cranberry. It's not. I bet the cranberry company, Ocean Spray would not want to have me as one of their speakers. Okay. Even the tablet, the extract doesn't do anything. The study that I read, it was randomized, so it's a really strong design of study, like scientific. And they gave extract, they gave juice, they gave tablets. Doesn't matter what you give. The people who had the cranberry side, they had as many infections as the other side. Okay?
What about once you have an infection to take the meds?
It doesn't prevent infections, and it certainly doesn't treat infections, because treating is even stronger. You need even more potent things to treat. So, doesn't do it. What's something that really does prevent infections, really can help your bladder? Estrogen. I'm not talking about local estrogen. Local estrogen, estrogen cream, estrogen ring inside the vagina. Now you guys are saying, wait a minute, didn't I read something about estrogens being bad and it causes this and that? That's the women's health study. We're talking about oral estrogen with progesterone has been shown to increase the risk of, a little bit of risk of blood clots and stroke, that kind of thing. But estrogen tablets themselves were not shown to be bad. And certainly estrogen directly applied to your vagina with cream reduces urinary tract infection, and it maintains health in that area. okay? Very little of that estrogen gets absorbed throughout your body. So I even feel comfortable giving it to my patients who have breast cancer, as long as their oncologist is on board with it. We give just a little bit of estrogen cream locally, okay? So I'm not afraid to do that. Now, we're not talking about pills, because what happens when you take a pill, it goes everywhere in the body. It's a big dose distribution. Local, fine, okay? You just don't overdose on it. Just take a little bit. Okay, so that's good. So what are the conservative therapy? What are the things that we do for urinary incontinence besides like the lifestyle changes that we talked about, the caffeine? One of the things that you can do is go to a pelvic floor physical therapist, okay? Yeah, there's actually a physical therapist that just specializes on pelvic floor. So they go to school, they learn all the regular stuff, on how to help people who've had hip surgery and stuff, but then they go on to specialize just in the pelvis. And they actually put their fingers in the vagina and manipulate different muscles and ask you to do all these things. They're very specialized. Why? Because these guys can help you with your stress incontinence, urge incontinence, stool incontinence, and it's effective if you do it correctly. Okay? I'm going to talk about Kegels in a second. But all of these things that I'm talking about, like the Kegels, if you do it correctly, it can be effective up to a point. Up to a point. Depends on how much damage you have. There's another thing called biofeedback. Biofeedback is something where you're doing these exercises, but you have sensors attached to your muscles, and you want to make sure that you're actually moving the right muscles. Because many of us, like when I ask my patients to do a Kegel, okay, has everybody heard the term Kegel? I don't have to, okay. So Kegel is, basically Kegeling is contracting the muscles around your vagina, okay? That excludes your abdominal muscles and your butt. So lots of times I see patients and I say, go ahead and do a Kegel, and they will close their thigh and contract their buttocks and quiver their abdominal muscles, and then you look at their face and the veins are popping out. Nothing's happening in my finger. Like, I don't feel any squeeze here. That's not a Kegel. That's not a Kegel. Let me show you something else here. Okay. Have you guys seen Suzanne Summers' Thigh Master? Have you seen that? Okay. This is not a Kegel. Okay? That's not a Kegel. You can't use the Thigh Master and improve your pelvic muscles. The Kegel is the muscle around your vagina. So the best way to squeeze that is to think, what would you do if you wanted to stop the stream of urine midstream? So you're peeing, midstream you want to stop urine. That's the muscle you contract. Or some people can't do that. The other thing I tell my patients is, what would you do if you didn't want to pass gas? Let's say you're at a party or social occasion. You'd probably squeeze your butt together, right? But also you could Kegel and hold that sphincter. Those muscles, you don't have very good control of one muscle over another. So as long as you contract that pelvic floor muscle that I showed you, that will maintain continence. Okay. Medications, okay? Medications can be helpful for overactive bladder. Yes? Yes. There's like a Kegel master and stuff. There's these things you can put in the vagina as long as it goes in. Right, that's what I'm saying. Those are not good. The things that work are the ones that go in. They go in and you have to squeeze them. So there's something called a vaginal cone, for example. It's these little cones that go in the vagina and they have different weights. Okay, so if you're a novice, you put a very light weight. And by contracting your muscle, you're supposed to be able to hold that cone in without letting it slip out. Okay? And as you get stronger with the muscle, you can put heavier weights in there. There's also a Kegel device where you put it inside, and you squeeze your muscles, and you can hear it, and you can squeeze it. Different amounts can be reached. Okay? So it has to be internal. It can't be external. Good question. So something you can do for your bladder, for overactive bladder and urge incontinence, is medication. Okay, you guys have seen the commercials, right? You've seen the commercials with the pipes. There's so many commercials on this. Or the ones on the beach where they're all happy and stuff. Okay, so The medications do work. They're not very potent, but they do work, okay? They work a little bit, and they can help. When you're doing these exercises along with the medications, it can be synergistic. So together they help more. What did they do? They stop the bladder from contracting. They do have side effects, though. They all have similar side effects. You know what the side effects are? Anybody on them? Dry mouth, constipation, dry eyes, blurry vision. Yeah. There's a new class of medication called a beta-3 agonist, so it's a completely different one. Not a lot of data on it, but it does relax the bladder also. So there's something new out there for people who don't want to have any kind of surgery, who don't want to have these other ones that cause dry mouth and constipation. There's another drug out there now. The other thing we can do is bladder Botox. We all know about Botox for wrinkles and stuff, but you can actually put Botox in the bladder and paralyze some of the bladder, not all of it. If you paralyze the whole bladder, it's not going to work. But just part of it so that it doesn't get so overactive and spasmy, and then you won't leak as much. Okay, so Botox that work. No, so Botox is not, you're thinking of collagen. Botox just paralyzes muscle fibers. That's what it is. Even for wrinkles, when you inject it underneath, it relaxes that muscle, so it allows the skin to kind of not be wrinkled. For the bladder, it'll paralyze certain parts of the bladder so that the bladder can't form a nice contraction wave, and then you don't leak. You would be a candidate if you've tried all these other things and you failed those things, then you could try Botox. Okay. Any questions up to now about these? Yeah. I tell people 7, 7, 7. 7 contractions, 7 times a day, 7 days a week, because it's easier to remember. 7, 7, 7. Okay? So 7 times 7, 49 a day. And the Kegels, you don't have to do all of them at once, or you don't have to do them within an hour. You don't have to go to the gym to do a Kegel. Okay? You could do a Kegel while you're sitting there right now. You could be doing a Kegel. You could be doing a Kegel. Say again? How long do you hold it? If you first start out, if you're novice, you usually can hold it for a second or two, but you want to increase that to up to 10 seconds. So initially you can just do it. Initially just do it. Contract that muscle, make it work. But there are 2 types of muscle fibers down there. There's the fast twitch and the slow. The slow ones work when you start holding the muscle for like 5 to 10 seconds. The fast twitch muscles work initially when you quickly close them, quickly do the Kegels. Those are the quick flicks. The quick flicks are the ones that help you when you're about to leak. Let's say you feel like, oh my gosh, I'm going to leak right now, or I'm on my way to the bathroom, and now I feel like I'm about to leak. You start doing quick flick, quick flick, quick flick, quick flick. Every time you do a quick flick of your pelvic muscles, it sends an inhibitory reflex back to the bladder to stop it from spasming and contracting. It's just like the knee reflex. So when I knocked on someone's knee, you're going to go like this, right? It's a reflex. When you do a quick flick of your pelvic muscles, it'll do a reflex back to the bladder to stop it from spasming, and it helps with leakage that way. Now, Kegels don't always work. I mean, they work up to a point. For mild stress incontinence, Kegels are effective. For moderate to severe stress incontinence, they're not effective. For urge incontinence, they can buy you some time and let you go to the bathroom. But you may have to do other things. Like you might have to see a pelvic floor physical therapist. You may need to be on these overactive bladder medications. And it's possible that you've done all that and nothing's working. Well, then we might talk about Botox. Or we can talk about exercises. We'll talk about that. I think I'm gonna come to the surgery in a second. I think the most common reasons that Kegels don't work are because, one, you're not moving the right muscle. You think you're doing a Kegel, but you're actually not. You're doing something else. You're moving your thigh muscles. Or 2, you do them for a very short period of time, and then you get bored and you stop doing them. Kegel is not something that you just do for a little bit of time. You have to keep doing it every day. It's just like someone who wants to bodybuild. If they want to keep that physique, they have to keep working out. They can't stop doing it. And then the last one is, what was the last one? The muscle is not working. Okay. The average person who comes to see me, someone like me, a urogynecologist, pelvic reconstructive surgeon, 5 to 7 years. They live with this condition 5 to 7 years on their own before they come to see me. And the reason is because maybe you didn't tell your doctor, or maybe you told your doctor doesn't know about this stuff. Because not all doctors know about this area. This is a new area. Some people have these myths. They think that it's normal to have this condition as you get older. It's normal to leak. It's normal to have prolapse. No, it's not normal. You can have prolapse, and it increases as you age, but it's never normal to have these things. Okay, so definitely see a doctor. The other thing is your insurance. Your insurance may not pay for this. If you have HMO insurance, they will try not to send you to a doctor specialist to have surgery because it's expensive for them. But if you have Medicare, Medi-Cal, any kind of private insurance, they will definitely pay for this. This is not a cosmetic procedure. This is not a cosmetic surgery. This is a real a medical condition. Okay? So this is what a pessary is. So if you have prolapse, we talked about pelvic organ prolapse, things are falling out, and you're not a surgical candidate or you don't want to have surgery, we give you a pessary. So pessaries come in different sizes and shapes, and the most common one is this one. It's called the ring with support. And what we do is we choose different sizes. You can fit someone with the correct size, and then it sits in the vagina and it holds your pelvic organs up. Okay? Do you think it's uncomfortable? It sounds uncomfortable, but it's not. It's actually not. People do fine. But I have two groups of women. One that I just can't even bear the idea of having this inside their body, and one that are like, yeah, as long as I don't have to have surgery, this is fine. You do have to come see the doctor every 3 months to have it cleaned and then replaced. Yeah. Yeah. The other option is, you're like, just do surgery and fix me. Yeah. The other option is for someone who can't have surgery, let's say. The other option is if they're able to take it out themselves, clean it and put it back in, then they can come to the doctor maybe every 6 months to a year. But they would need to do this once a week at least to take it out, clean it, put it back in. So that just doesn't sound like, a lot of people have the same reaction. They're like, no, I don't want this. Just fix me. Okay. All right, so what are the different surgeries, okay, for all these conditions I'm talking about? The different surgeries, for the stress incontinence, there's a very good surgery called a suburethral sling, okay? And it's about a 15, 20-minute procedure in the operating room. It's outpatient, but you're in the hospital 2-3 hours, and then you go home. And you should theoretically immediately be cured of the stress incontinence. It's about 90 to 95% effective. So of all the surgeries that I do, this is probably the most bang for the buck, this one right here. And the recovery time is pretty short. You could have this done like on a Thursday or Friday, and then maybe be back to work in about a week. Okay? For prolapse is a bigger surgery. And in the past, we used to do, yes? This? Yes. So there are only certain types of pessaries that you can have sex with, and this is the only one. This is one of the only ones. The manufacturer says you can't have intercourse. When I talk to my patients' husbands and stuff, they may not like it, but you can. You can have sex with this in place. Yeah. Maybe it feels like a ripped condom. I don't know. But you can, yeah. So very good that you mentioned it. So let's talk about mesh. So I didn't want to go into a whole thing. That's why I wrote a book there, by the way, because that explains the whole mesh thing, hysterectomy, all that. We'll talk about that. But meshes have been used in humans for about 80 years. Okay, we've used mesh in different areas of the body. For example, general surgery, general surgeons use mesh to fix hernias. Okay, that's abdominal mesh. Back in 1996, they came up with this revolutionary procedure called the TVT. It's a sling procedure. And it worked out really well. It was a high rate of cure, did well. They eventually brought it to the United States, and then it just went like crazy. Everybody started using these. Then these manufacturers in the United States said, well, why don't we try to do this mesh stuff for prolapse? Make a kit, because this is like a little kit. Take a kit, make it a little bit bigger, put some more needles on it, and then let's fix prolapse, because this is highly profitable. So they started to have these vaginal mesh kits for prolapse, which are much bigger things. And that caught on quickly also, because it was not very difficult to teach and do. And people started doing them without much data. And so the vaginal meshes for prolapse are the ones that developed a lot of the complications. And these complications were reported to the FDA. And then FDA came out with a warning statement, a very light one in 2008, and then a stronger one in 2011. That basically you have to be careful with, with mesh products. And they kind of came out with a very generic statement, because they always do. They don't come out with anything specific. So the societies, my society, called the OGS, there's a urological society, SUFU, all these societies came out with a guideline, okay, from what all the medical evidence and literature and what we believe, and this is the guideline. For slings, suburethral slings, and for sacral colpopexy, which I'll talk about in a second right here. It utilizes mesh, but it's safe, okay? For vaginal mesh for prolapse, where you make a cut inside the vagina, and you use a big piece of mesh, and then you close that incision, okay, not so much. The data is not so hot on those things. So the vaginal mesh for prolapse, no. Sacral colpopexy, which is an abdominal mesh, and slings, which is a very small mesh, yes, it's okay. Okay? And we can talk a lot more about that. And if you want to know more, read my book, Chapter 3. It explains the whole thing. Okay, so for pelvic organ prolapse, the main ways that we can do surgery for that are, in the past we used to just open people up, nice big vertical incision or a bikini incision. Now we do it minimally invasive. So you can make like 5 little holes on the belly for the sacral colpopexy, or we can do the entire procedure through the vagina, transvaginal without any incisions. Okay, so they're both about 3 or 4 hour surgeries, one night in the hospital, about 6 weeks recovery. Okay, there is a drawback to the vaginal surgery, and there's a drawback to the robotic, the minimally invasive surgery, and I'll go into that if you want to talk about that. I'll just move on to the next point, and it's just so we finish, and then you guys can ask questions. We talked about the overactive bladder. If the medicines don't work, if the exercises don't work, if my insurance company won't pay for Botox, what can I do? You can do something called sacral neuromodulation or a bladder pacemaker. There's a pacemaker that we implant just below your spinal cord, so it's not dangerous. And it actually paces your bladder so that bladder doesn't just kind of, contract on its own will. It'll pace your bladder. It's not dangerous to do, and the implant is about this big, and it goes right underneath your skin right here on the back, and it can be effective for 3 to 5 years. And it's very potent. Okay? This is, remember the sacral colpopexy or the surgery for prolapse, pelvic organ prolapse? That surgery used to be done this way a few years ago. Now we're doing it this way. 5 little incisions. I am now using robotic surgery to do this. So everybody wants to hear about robotic surgery, so that's why I have a slide on this. Basically, robotic surgery, it's not something it sounds futuristic, but it's not really. What it is we make 5 little incisions, we put instruments in through those incisions, and we put a camera in. Then we attach the robot to those instruments and the camera, and then the doctor goes over there and sits down, puts his or her head down into a little screen. And when I put my head down, I am now inside the body. I can see 3-dimensionally everywhere I'm looking. I'm inside the body. And then I have a little joystick here that I can move the instruments. Yeah, I have one joystick. I've got some pedals here. Now, why would yeah, I do like to play video games, but why would I want to do surgery with a robot? Huh? It is more precise. It's more precise. I don't have to stick my whole hand in there. This robot allows me to do same exact movements as my hands and my fingers without having my hands in there. That means I don't have to cut you open as big. Okay, so that's the advantage of robotics. There's been a recent article on the cost of robotics. Yeah, that's an issue. The cost of robotics is more of an issue when we talk about simple surgeries, like a simple hysterectomy. You don't want to do that robotically. That's like taking a big sledgehammer for a little nail, Sorry. But as the surgeries get more complex, robotic surgery is going to be the way to do it. That's going to be the way to go. We recently, but how many weeks ago, Dr. Yun, did we do that single site? We did the very first, 3 weeks ago? We did the very first 1 incision robotic sacral colpexy ever recorded through one incision. And I think really that's where we're moving in the future. I think all the surgeries will be done through the belly button, if they can be. And it'll be done robotically because the robot allows you to do what you need to do. Why do you have to cut people open? So that's where we are with technology. Really quickly, I just want to plug my book. I wrote this book called What's Going On Down There, and Dr. Oz was nice enough to give me a little commentary on that. And the reason I wrote this book was because I've already mentioned it, but there's lack of knowledge out there. There's a lot of myths about, these things are part of normal aging. They're not. They're not normal. And sometimes, many times I see patients who have been kept from seeing me for like 10 years by the insurance company because they don't want to send the patient over, like HMO usually. They don't want to send the patient over because all of this stuff will be costly. It is costly. I'm not going to lie. Costly to get these things fixed. But once you fix it, it really changes your quality of life. The other thing is a lot of people go on the internet and they search all these things. There's so much stuff on the internet, but it's hard to kind of put it together. Like, what does this mean for me? So this book really explains all that stuff. Really quickly, these are the topics I cover, and I know you guys have the handouts, right? Those, I don't. I didn't think they were going to, I've done this for 5 years. I've never had this many people. This is the first time. I wasn't expecting it. I'm blown away. It's the colored one. It's a thick colored one. Yeah, I didn't expect such a turnout, but I'm very happy that you guys came. Is my time running out? I'm okay?
I have a question.
Yes.
I'm very interested in the pacemaker because I think that's my next step because I'm on vessel care.
Vessel care.
Vessel care.
Uh-huh.
And the day after Thanksgiving, I conked out. They thought I had a stroke because I cannot drink enough water.
Mm-hmm.
I don't think for the dry mouth, and I had such dry mouth, and they thought I had a stroke.
Mm.
But then they decided that it was dehydration.
Mm-hmm.
Because I wasn't drinking enough
You didn't want to because you were like the second person I described that didn't want to drink too much.
Well, I thought I was drinking enough. I do drink a lot of water, but obviously it wasn't enough because they described it. I mean, I was taken to emergency. They called my son had to call 911. I was taken to emergency, and I was out of it even when I got to the hospital. And they described it. I mean, they diagnosed it as dehydration from the medicine. And so they said, stop the medicine. Well, if I stop the medicine, I mean, I have to do more than diapers.
Yeah. The Vesicare.
I really have a bad bladder, but I've had it fixed. I mean, I have a strap that's still in place and everything. So what's my next step?
Well, there's a lot of stuff going on. What you're telling me, you need to come see me. But Vesicare.
I'm going to come see you, but I am going to a urogynecologist in Newport Beach, Dr. Matthew Clark.
Yeah, I know him.
You know?
Yeah, you should know what to do. Maybe he's not. So Vesicare doesn't cause you to get dehydrated, but it causes you to have dry mouth. You get dry mouth.
I carry big bottles of water
right,
like this.
which makes you drink more, which then makes you pee more.
Yeah, I can't hold it. So I'm just damned if you do it, damned if you don't. So I don't know what to do. So I'm
So talk to him about the pacemaker. There's something else called a tibial nerve stimulation. Talk to him about those two things.
Well, I have a strap. I have a strap. I mean, I don't cough and wet my pants. I don't do any of that.
And that's stressing
I don't leak. I don't do anything. I'm like Niagara Falls. So when I saw that pacemaker, I thought, oh my God.
The pacemaker would if you. I mean, it's easy to do. I think he does it. I think he does do the pacemaker, but ask him.
If he does it, I don't care if you do it or he does it, but
Come on over to Loma Linda.
I will. I have excellent insurance. I will pay for it.
Okay. Yes.
I have a question. You mentioned the estrogen ring.
Uh-huh.
So I tried the cream, and it's a pain. I mean,
Yeah.
take it every night, and every other night,
Yeah.
and 3 nights a week, and then
The estrogen ring is a really good option for. We talked about local estrogen in the vagina, that helps prevent urinary tract infections and keeps the tissue healthy. Estrogen ring releases estrogen, small amounts that don't go throughout your whole body. It just stays in the vagina, and it's good for 3 months. It's called an S string. So definitely talk to your doctor about that. Yeah. Yes. Yes.
I had the pelvic organ prolapse. I had surgery. now they're thinking I have the interstitial cystitis. How do you, my neurogynecologist is saying it's very hard to diagnose.
Yes.
I mean, I've had tests that are kind of ruling out things.
Right.
What is the way to?
So interstitial cystitis, or IC, is a diagnosis of exclusion, which means you do all these things and make sure you don't have these things. Like you don't have cancer, you don't have an infection, you don't have tuberculosis in your bladder, you didn't have radiation. All of these things, you don't have that, and once you can say you don't have that, then you get into this wastebasket category called IC. There is no... Elmeron it's an FDA-approved medication for IC, but it's not very potent. I mean, it works, but it's not very strong. Some things that have panned out for IC that could help with IC, certainly you got to watch your diet, what you eat. Don't take any acidic foods. Physical therapy is actually useful for IC. Pelvic floor physical therapy. There's the bladder pacemaker that I talked about. That's a off-label use that could help IC. There's an antidepressant out there called amitriptyline. It's an antidepressant, but it's also been shown to help with IC. So there's different medications out there that can be helpful. Okay, good question. Yes?
How much is your book?
Oh, my book. My book is $20. Feel free to come in and I'll sign it for you today. Only today, no. Thanks for asking. Yes?
This is embarrassing. I hope I don't know anybody in this room, but is there any sexual positions that tend to irritate the bladder?
It's highly individual, and it depends on the shape of the penis and your anatomy and stuff. So, but I ask my patients, what positions are you more comfortable in and stuff. So yeah, there is. Yes.
And they are?
Depends on the patient.
Got your screenshot that was saying that elite extreme athletes. I noticed gymnastics. I have a 19-year-old daughter that's done 12 years of hard gymnastics. She's also done cheer, competitive cheer.
Yeah.
What's the prognosis of her having this earlier than later?
Yeah.
Because if I have to, I'll do preventative now.
The only preventative thing you can do with her right now is the Kegel, the pelvic exercises. We don't have any data to show. We have never followed elite athletes throughout life to see how many of them end up with this. But theoretically, it does make sense that there's more impact on the pelvic floor. Kegels, I'll bet you she would be very good at doing that, and that would keep her muscles strong. That's a good question. Yes, there were some other questions here, and someone had asked in the beginning. Did somebody ask about vaginal rejuvenation?
Yeah.
Who was it? Yes? Yeah. Okay. So vaginal rejuvenation is this concept of tightening the vagina, making things look prettier down there, okay? When does it become, it's not always vaginal rejuvenation. I've had patients who have had maybe 6 children, and they say, doctor, I don't enjoy sex anymore because everything feels loose down there, and my husband doesn't feel me, and he doesn't feel anything. I don't feel like that's vaginal rejuvenation, but that could be considered a medical issue, and you can come to a doctor like me, and you can get tightened up down there, and it's a simple procedure, probably an overnight stay, where the vaginal opening will be narrowed. It's not going to be exactly back to the same way it was when you were a virgin, but it'll be narrowed. Another indication, or medical indication to me, that's not cosmetic, is somebody has the labia minora. Those are the small lips. The small lips get really big, either from an infection or from irritation, or maybe someone has been doing exercising a lot or something, and the labia have been rubbing against each other, and they've gotten kind of long. And so now every time they want to do something, some kind of activity or sports, the labia are so large that they now rub up against each other and bleed, or they're very uncomfortable. Okay, so in that case, what we do is a labiaplasty, where we reduce the size of the internal labia. Okay, so those are the main medical indications. Everything else beyond, is cosmetic. So a cosmetic indication would be like, doctor, I looked in Playboy and I want to look like that, and I don't look like that. Okay, that would be cosmetic. That's not paid for. It's by your insurance company. Okay.
If you have a problem, it is
If you have a problem, and there are certain measurements, like you can't have a 1 centimeter labia and say, I have a huge problem. You've got to have a certain number of centimeters, right? And then along with the history, and then the insurance company usually says yes. Yeah. There was some other question about something, yeah.
I've been seeing commercials about Osphina. It's pronounced Osphina. It's for like vaginal dryness.
Yes. It's called Osphina. By the way, I have Dr. Josh, I didn't want to put you in the spotlight. Dr. Josh Shun is my fellow, and he has done, and I'm going to come back to your question. He's doing a 3-year fellowship with me. So he's already done a residency in obstetrics and gynecology, and he's been in private practice for several years. He came all the way back from Washington to work with me, and he's been working with me for 2 years. So the reason I point to Dr. Yun, he may know, but Osphina is a very new drug. It's a SERM, it's a selective estrogen receptor modulator. It's very new, and we don't know that much about it. And personally, I don't know that much about it either. Dr. Yun, do you know anything about Osphina?
I never used this. I don't have much personal experience.
Yeah. What's the specific question related?
I was just wondering if that would be like the same thing as like the estrogen ring, or if it's
Yeah, no, it's different. It's different because the SERMs, the category of drugs, they have positive estrogen effects on certain tissues, and they have negative estrogen effects on other tissues. And there's so many of these SERMs that you have to know exactly what that specific SERM is doing. Okay, for example, there's some SERMs that positively affect the uterus, and they'll make the uterus grow and maybe bleed, and then negatively affect the breast, or negatively, so you can't really, you have to know exactly what that is. So I don't want to give you a wrong answer, and I don't use it. Yeah. Yes. Yes.
Can you talk a little bit about concerns about HRT?
Yes. The main concerns with HRT, I think, came with the women's health study back in the early to mid 2000s. And it was really this was a big study of like over 16,000 people who were followed over time for several years. And the studies were stopped short because of some adverse events that had occurred. And the main adverse events occurred in the group that had both estrogen and progesterone. And the two biggest things were thromboembolic events, so blood clots in the brain and in the legs. And blood clots in the legs can be dangerous because they can go to your lung and cause pulmonary embolus, which can be life-threatening. There was a slight increase in breast cancer risk, but it was not. It was only the risk. The risk of death from breast cancer did not change. But that was really the main thing. It was blood clots, increased risk of blood clots.
So is it deemed to be fairly safe now?
So it really depends on your history and stuff. So yeah, now it's very difficult to give someone estrogen and progesterone that way. So if somebody is a candidate, let's say you're having hot flashes. First of all, if you're having hot flashes, there's a lot of conservative things you can do before you even get to estrogen, right? For example, what are some things that people do, okay? Anybody want to give some ideas? You're having hot flashes, you don't want to take meds. Ice, cold.
The caffeine and the wine.
Right. Get rid of the triggers, whatever that is, if it's a spicy food or wine or something. Chocolate. Cool down the temperature in your house. Okay, maybe not use right? Those are the easy things you can do. I mean, there are people, and I'm not suggesting this, but there are women in other countries, other cultures that just live with hot flashes. They don't even have access to estrogen. But there's some conservative things you can do. Then you can go up the step. Now there are, you can try the GNC stuff. There's certain herbals and stuff. None of the herbals have really panned out except for soy products have estrogen. But you have to take an enormous amount of those to get the estrogen. So really the next step up would be your non-estrogen drugs. Okay, so some of the antidepressants like Prozac. Prozac can be effective for hot flashes. Yeah. So taking it in low doses, it can help. And then you go to the hormones. Hormones are the last thing that people try.
Yeah, I'm on patch and also on the cream.
Okay. And so if you're going to take hormones, nowadays what I would do is give estrogen If it's for hot flashes, give estrogen pills, and then give the progesterone in a pill form either through the vagina. Give the estrogen as a patch form, and give the progesterone as a pill in the vagina. Why patch form? Because the estrogen that's absorbed through your skin doesn't induce the clotting factors in your body, because those were the problems, right? The clotting. And so they're less likely to make you clot. And yet you're still getting the estrogen. Okay, and then the progesterone that they used for the women's health study was a synthetic progesterone. We can use a more natural prometrium and put it in the vagina and just give you enough local absorption for your uterus, because that's really what needs the progesterone, is the uterus, to protect you against the estrogen. So if you have a uterus, let me bring it to another level here. If you have a uterus, and if I just gave you estrogen by itself, either through your skin or mouth, that would be bad for you, because it would stimulate your uterus, and eventually your uterus could become cancerous. Okay? So you need progesterone to protect your uterus from cancer, from the estrogen. That's why we give estrogen plus progesterone. If you don't have a uterus, then you can just give estrogen. It's fine. Okay? But if you have a uterus, you have to have progesterone. The studies that you were talking about, they took oral estrogen synthetic and oral progesterone synthetic. Okay? Now what doctors are doing is giving estrogen transdermal, progesterone like bioidentical through the vagina. Okay? So that's the way to go right now.
Is that in your book?
That's in my book. Yeah, I have a whole chapter on menopause and hormone replacement. Yeah. And all the herbs, and we have a whole thing on all the herbs, which ones work, which ones don't. Yeah.
Well, how old should you be, taking estrogens at post-menopause?
Right.
I know they said 6 years for Premprol and stop.
So there is no cutoff age on when you can take estrogen. But when these studies came out, these women's health studies were on people who were already menopausal. They were years after they went through menopause. The group that it really helps is the ones that are going through menopause, not that they were in menopause like 6 years ago. So there is no cutoff age. Some doctors initially, like when these studies came out, and then after the backlash and 2 years later, they said, you should try to avoid estrogen after 65. But nowadays, doctors, you can get estrogen up to your 70s. You can keep having estrogen as long as you're careful and as long as you understand some of the risks and you're taking it the way I'm talking. The patch and the prometrium, depending on if you've had a hysterectomy or not. You have to find a doctor that knows about this stuff, and they can guide you. Yeah.
Sorry. What about aging? I hear that that there are some benefits as far as taking the hormone replacement, as far as aging. Right.
So estrogen has been shown to reduce like collagen turnover and stuff. So you have less likely to be get wrinkles, and so there are a lot of positive effects. It's good for your bone. It keeps your bone strong, so it reduces the chance of osteoporosis. That's the biggest thing, is that as we get older, our bone density gets less, and then we're not very active. And so if something happens and we fall, our bones are now more brittle and they break. If you have a broken bone on your hip, that's a big problem. A hip break can lead to someone's death. Okay, it's a really big problem. So estrogens have been shown to maintain bone density, even in menopausal women. So there's a lot of positive things about estrogen. And that's why it was such a big controversy when that came out, because there's so many good things about estrogen, and now this study is telling us we can't give estrogen. Yeah. Sure. Yes.
What about women who have had DCIS, ductal carcinoma in situ?
Of the breast.
Yes, and they're told to desist all estrogen products.
Right. So, like I said, I feel comfortable even in my patients who have had breast cancer. They actually took their breast cancer, even in those women. As long as I communicate with their oncologist, we have a good communication, and this person is suffering, she has atrophy, she has all these problems, just use a little dab of estrogen down there 2-3 times a week, as long as your oncologist is on board with me. Because the studies are not against that. It's just people's fear. They fear that if they gave a little estrogen, it would go and stimulate this ductal carcinoma, and now you're going to get cancer spread out. That's not how it works. Those are all theoretical risks. It doesn't, in real life, it has not panned out. So I would have your doctor talk to your oncologist, get together, or maybe talk on phone, by the phone, and then maybe come up with a dose for you, a comfortable dose. More questions?
So, okay, so you say that the estrogen vaginally does not absorb through your body.
Right, given not if you get globs and globs of it, but given the amounts that I'm telling you, not really. And that S string that they asked me about, almost nothing. Not very little systemic absorption.
Or not, because when you have a patch or other medications are
Yeah.
put on, a cream goes throughout your body.
Yeah, that's a much higher dose. Yeah. The ones and that's why I'm saying you put a certain amount of cream. Yeah. Yeah. You can use estrace as long as you, like I tell my patients, 0.5 gram, 2-3 times a week. That's not much. If you were using 4 or 5 grams, then it does. Yeah.
So is that effective in and of itself, like for vaginal dryness?
Yes, it is. Estrace cream, like we said. Mm-hmm. Yep. Any other topics we want to talk about? Hysterectomy? That's usually a topic people want to talk about. No? No hysterectomy? How to find the right doctor? Okay. Yes?
So for stress incontinence, you'd say that the sling is the best route to prevent that or fix it? And if so, what kind of surgery was it again? Like laparoscopically?
So if you have stress incontinence and it's moderate to severe, if it's mild, you can just do Kegels, and that's fine. If it's moderate to severe, the easiest, quickest type of fix is a sling procedure, and there's 2 types. There's the TOT and a TVT. The TVT has 2 little incisions above your pubic bone and a small incision inside the vagina. Okay? The TOT has 2 little incisions in the groin and 1 in the vagina. They're very effective. Both are very effective. They're just different routes. But it places a small, safe, synthetic material underneath the urethra, and then it supports your urethra, so when you have a full bladder and you cough, your urethra pushes against this material and it closes, it kinks off, and you don't have leakage. Yeah.
So you say about a 20-minute procedure and in and out?
In and out for that procedure, yeah.
So why do you hear on TV all this stuff about
Oh,
the lawsuit?
that was Dr. Yoon. I actually explained that about 20 minutes ago. Come up afterwards and I'll explain it to you again. But I did to the group. Yeah, I'll explain it, the mesh, what the mesh is. Okay, guys. Yes, one more.
Okay, Andrew, how to find the right doctor? Do you know if Kaiser has a specialty?
Kaiser does. It's Fontana. Are you part of Kaiser Fontana has 2 people in my specialty. Yeah.
How about Riverside Medical?
Riverside Medical, I don't think they do.
So if you have HMO, then they refer you out?
Refer out, yeah. And just be aware, if you have an HMO and you go to your primary care doctor, they tend to refer in the network to a gynecologist, which is not what you want. You want to go to the specialist who does this. So that's the thing with HMO. And so what keeps happening is that primary care sends a gynecologist, nothing's happening, then back and forth. You want to get out to whoever is going to help you. You're a gynecologist or a female urologist.
So can your gynecologist know that you have this? I mean, because I'm like, okay, how do you know? Do you all of a sudden you're like, you got,
They can.
hanging out of there? Or, but most of the time you see your gynecologist, you're laying on your back.
Right.
So.
They can if you tell them about it and you ask that something be done. Yeah, you have to tell them that this is bothering you. It's affecting you, and they know what this is. Whether they're going to fix it themselves or refer you to someone who can, that depends on the gynecologist. Yeah. All right, guys, you guys have been an awesome audience. Please come up if you like. Thank you.